Namaste and good evening. I am Mahima Kapoor, researcher and assistant editor at IMPRI, Impact and Policy Research Institute, Prabha एवं नीति अनुसंधान संस्थान नई दिल्ली. Welcome you all to the IMPRI #Web Policy Talk. The COVID-19 pandemic has underscored the importance of timely data collection and sharing and the usage of data for decision making. To understand how data informs vigilant response and supports preparedness towards pandemics, we have gathered for a panel discussion under the series, The State of Population and Development, #Population and Development, on population data and pandemic preparedness. This deliberation is being organized by the IMPRI Center for Human Dignity and Development. I feel honored to introduce the moderator, Mr. Devender Singh. Sir is a Global Studies Program Fellow, University of Freiburg, Germany, and Visiting Senior Fellow at IMPRI. Welcome, sir. I feel privileged to introduce the eminent panel for today. Dr. Venkatesh Srinivasan is a public health and development professional and previously with the United Nations Population Fund. Welcome, sir. Ms. Urvashi Prasad is the Director, Development Monitoring and Evaluation Office, NITI Aayog. Welcome, ma'am. Professor Mala Ramanathan is a professor, Achyuta Menon Center for Health Science Studies, Shri Chitra Trinu Institute for Medical Sciences and Technology, Thiruvananthapuram, and Working Editor, Indian Journal of Medical Ethics. Welcome, ma'am. And Dr. Kunal Keshri is an assistant professor, G.B. Pant Social Science Institute, Prayagraj. Welcome, sir. Now I invite Mr. Singh to take the proceedings further, and we look forward to learning from our esteemed gathering. Thank you.
Thank you very much, Mahima. First of all, let me once again welcome the distinguished panelists, and also to share that I'm very excited because this theme has been very close to our heart from the time when we were working, both Venkatesh sir and I was working, we were working with the UNFPA. Because at that time, COVID-19 started, and we were working very closely with government, Ministry of Health and Family Welfare, as well as NITI Aayog. WHO was mainly involved with the epidemic data and tracking the epidemic. But what we were seeing that there was paucity of data. Most of the agencies, experts, they were saying that we need to have better data. Data group at the UN, they were working together to create a framework to collect data from different sources and to track the epidemic. Later on, not only UN agencies, but every agencies, and not only in India, in other countries also found that data availability and data usage in predicting the behavior of the epidemic, as well as countering or mounting a effective response to the epidemic. The need of data, timely data, usable data, cross-comparative data, that need was felt. We at UNFPA, because we work with the, we used to work with the population data, then we also thought of that apart from the regular data, health management information system data, could there be other data also which could be used to predict the epidemic or its trajectory? And from there, the need for this kind of discussion started at that time. And I'm happy that IMPRI has taken the initiative to organize this talk. which we are calling panel discussion, but as I wrote in my email, it will be more of presentation and discussion. So we will be hearing from the expert panelists on different themes, covering different areas within this theme of how to use population data, or how to find population data to prepare for the pandemic. I also want to share that this theme we have taken, this is the first session which we are organizing, and we plan to organize many sessions under the overall broad thematic unit within the IMPRI, that is population and development. Because we think that somehow when we talk of population, we talk of demographics and demographic data in isolation of its linkages, consequences with the development. And when development experts they are meeting, they don't know what kind of impact or effect demographic factors have on development. Also, academicians, they work within their institutions and organizations. Policy makers, they work with different mindset within the government and think tanks. We also thought if we can bring them together, where academic insights are shared in a language which could be easily accessible to the policy makers, and policymakers also can tell the academicians and experts what they are looking for, what are they missing when they think of formulating a policy or a program. So we are thinking of creating a platform also, or what we say, a group of practitioners where the two can come together, and also the young researchers, so that they can learn how to combine the two, and then take different themes within the population development interlinkages and organize similar kind of sessions. So that is the overall aim, and how we can disseminate them, how we can reach to a wider audience that IMPRI is thinking of, through reports, through maybe a compendium later on when we have organized a certain number of sessions, and also through the like Facebook Live is there, videos will be formed, small videos, so that we can reach to the wider audience, not only the people who Zoom in for a particular session. So not taking much time at the beginning, and I think all the who have joined in are more eager to hear the experts. So not delaying further, I invite Professor Ramanathan to start with her presentation.
Thank you, Mr. Singh. And at the beginning, I should say that I'm really not an expert. I'm more of a data user. And many of the things I'm talking about comes from scouring all over to see how best in helping others as a demographer on how best they can use the existing sources to track anything, including the pandemic. And so what I'm going to speak comes from struggling over the past 2 years to educate colleagues, epidemiologists and other people working in public policy about the advantages and disadvantages of existing population data sources in the country. So, it's not so much of expert as much as a data user that I speak. So it's very important for me to add this disclaimer that these presentation, the opinions expressed are my own and do not represent those of the institutions to which I'm affiliated. I'm also grateful to Dr. Uday Shankar Mishra, Professor IAPS Mumbai, for a useful discussion on this topic, which helped me to collate this presentation. So what are the existing data sources for planning and monitoring vital rates? And many of you must have seen this discourse, the census, the delayed census, etc. India's backbone of planning is the decadal census that has been conducted synchronously since 1881 across the country. It was due in 2021 and was interrupted due to pandemic conditions. It is very, very important to recognize why the census has primacy. There are two reasons. One is almost the whole country gets counted. It gives us, for every estimate we make, the denominators. There is no rate without a denominator. And therefore, the census is the backbone of all our planning, especially in the area of health and development. And this reporting to the census and its restriction from use in any other forum, it's a legal requirement for a citizen of the country to report to the census according to the Census of India Act of 1948, Section 8(2). The other one, which we have for monitoring deaths and other vital events, it doesn't give you morbidity, but definitely death and cause of death, is the civil registration system. For some reason, this is the least spoken about mechanism of monitoring a pandemic in the country, and that is also bound by the legal requirements of registration of births and deaths in the country. We have legally required to report it within 21 days. The next one, which is a sample registration system, actually provides reliable estimates for births and death rates for rural and urban areas across the country for states. The other important source is the National Statistical Office, which is the old National Sample Survey Organization's various surveys on economy, consumption, infrastructure, health, education, migration, and a whole gamut of topics. There are other resources that have gained currency and incredible credibility, like the National Family Health Survey, of which 5 waves are available. The earlier demographic health surveys, which were 3 waves were available earlier, which is now coterminous with NFHS. The IHDS for development, 1 wave is over, the second wave is 2 waves actually, I'm sorry. And the longitudinal aging survey of India, that is another wave 1, and the global adult tobacco survey, of which 2 waves are over. There is a plethora of data sources, many of them in the public domain, that are actually available. But, having said that, each one comes with limitations. I have said that it is necessary to report births and deaths, the civil registration system under the law. It can provide data on the deaths. However, it's reporting how many of us, each one of us, can actually think of the people in our families, in our extended circles, where a death occurred for which a death certificate is not available. It's very common practice in most parts of India that unless there is some inheritance or a legal requirement, we don't, for birth certificates in today's world, yes, by and large, within a period of 3 years before entering school, there is a higher chance of registering a birth, but a lower chance of registering a death. And therefore, you need to realize that registration, I'm giving you only deaths. It is improving in the civil registration system, but it's not uniform. Across India, in 2011, it was 66.4. And in 2019, it had improved, significantly improved. And this is the most recent available in civil registration. 2019, we have 92% registration. But you look at the variation across the country. Kerala has 100% registration of deaths, whereas Bihar, even in 2019, had registered only about half of the expected deaths. So, while the civil registration system does record deaths, and some of those deaths, we have the cause of death, it is not a complete presentation of all the deaths, and therein lies its limitation. Why people, there are two reasons. One is very few people know about its existence and its utility. And the second part is its serious limitation because of the incompleteness, ununiform completeness across states. So this civil registration system does report the level of registration, that is the extent to which deaths are reported for counting against the actual number of deaths. And again, it's not, like somebody counted the deaths. They come up with an estimate of the number of deaths that are supposed to occur. This is based on the sample registration system, which is another source I mentioned, and it is structured to provide accurate estimates of births and deaths by age for states and union territories. The sample registration system is independent of the CRS, and therefore, it is a useful tool for triangulation. We can use it by adjusting the number of reported deaths against the actual number of expected deaths. We can actually project deaths and the expected number of deaths with some modicum of accuracy. So yes, we can use the civil registration system to monitor the deaths, but can we monitor the deaths by cause of death? Counting the dead and counting the dead by why they died is what is a serious problem. The cause of death in Indian statistical system produces data on causes of death by the states using SRS data. The most recent published version is 2007-13. This is based on SRS, and it is not validated through any external means. For recent years, there is an alternative source that has been computing the cause of death statistics, but what we have publicly available is only the published record of 2007-13. So that brings us back to the alternative, the CRS. Medically certified deaths? Yes, medically certified deaths are extracted from the CRS. The most recent report available is 2019. Cause of death reported with the medical certificate available through a panel of, hospitals which are prefixed to report. And this gives us medically certified deaths. But look at the proportion of medically certified deaths to even total registered deaths. In Bihar, it is all over India, it is 20.7 at the current moment, the most recent one. In Bihar, it is 5.11. Even in a state like Kerala, the proportion of medically certified deaths to total registered deaths is 11.6. But Kerala, in a sense, is better because all deaths are registered. So the sample registration system, which I've been talking about, which gives us cause of death statistics. Now, why is it that people haven't demanded that the SRS give us, a means of monitoring the pandemic deaths? The SRS, yes, can be asked to provide the data, but the SRS in 2021, you look at it, the sample registration system sets up a panel every 10 years and fixes that panel for rural and urban sampling units for estimates of births and deaths over the next 10 years. In using the Census of India 2011, in 2014, this panel was set up. We do not have the census 2021. So until the census is over, updating this panel is fraught with problems. So what happens if the population which you're going to use is fixed and you continue to use the same sampling units to make estimates? There is a natural cohort attrition. That means the people who have to have births have had births. People who are likely to die are dying. And so your population, while the births are more in India than deaths, there is a natural process of attrition in that cohort from the time it is set up that continues to occur over the years. And we are very close to reaching the mark when it has to be changed. Therefore, Look at the confidence intervals that come from sample registration system for the death rates. Very narrow for all India. Wonderful. So we can rely on, the sample registration system's death rates. Even though we don't have information, we can ask for cause of death as the people reported. We can use it. But look at the confidence intervals, very, very narrow. Uniformly about 1.1 or 0.2, so reasonably reliable. But are the death rates uniformly reliable across states? Just look at the 95% confidence interval when rural and urban rates vary, and I'm giving you only the total. Death rate for total 6.4, it ranges 0.6 here. Bihar, the range is again 0.5. Why is it more narrow for Bihar? Why? Because Bihar is a large state where fertility and mortality have remained more or less declined very slowly. Therefore, your confidence intervals will also be equally narrow. You take the states where declines are likely to be faster. Example, Kerala. 7.1 is the death rate, but look at the confidence interval, 6.7 to 7.6. It is very, very wide when compared to Bihar. Look at Odisha. 7.1, but 6.8 and 7.5. Uttar Pradesh, the overall death rate is 6.5, but look at the narrowness of it. So the reliability of that rate that you get in the SRS itself is not uniform across states. So how can we verify the validity of any data source? By checking for accuracy internally, that is consistently done across all data sources. Triangulation through external means, using the SRS to validate the CRS. That is something we can do and we should do on an ongoing basis. We need to, talk more about these things on an ongoing basis to epidemiologists and others. This SRS gets compromised because as the SRS moves closer to the census years, the confidence intervals are going to widen for the states where mortality declines have happened. So we need to take cognizance of that. So even though the overall rate is valid, it is not uniform across the states. What other sources have helped in the context of the pandemic? Whatever data, what's and all, we have to make use of them. People have tried, some have succeeded, some have failed, all of it in parts. The Indian statistical systems have in the past come up with wonderful mechanisms to provide indirect estimates for many necessary vital events, even when data and that talent exists within the country, a country which produced people like Mahalanobis set up the Indian Statistical Institute, is a country with phenomenal but hidden talent. The Office of the Registrar General of India in the past routinely produces indirect estimates. We need to strengthen that skill to look for indirect ways and means of measurement. We need to build on that. We can use the CRS, come up with better estimates. So what do we need to do? We have to for sure make sure our census, that is the backbone of Indian planning, gets conducted. We have to strengthen the CRS because it is an individual need. People need to register birth and deaths. It's also a civic duty because it gives us accurate rates. So we need to strengthen the CRS, create mechanism of monitoring these deaths and causes accurately in a decentralized manner, which is without blaming individuals in positions of power or systems. Only when we make autonomous our data collection mechanisms without politicizing them will we have accurate data. We have to strengthen the statistical systems within the ORGI's offices because they have the data, they know its limitations and they know its strengths. And elsewhere, and use all these resources to provide vital rates, including pandemic planning. We need to identify and nurture those skills, which gave us indirect estimates for almost anything to, create that magic to give us estimates which exist within academia and elsewhere as part of a larger scheme of planning for pandemics and preparedness for anything within the country. I know that the skill exists, but it is rendered invisible because of serious misgivings and many other factors. We need to find and nurture those skills as well. Thank you.
Thank you very much, Professor Ramanathan. You said you are not experts, just a data user, but we can see your expertise and how you have touched different data sets and the lacunas or shortcomings they have and what needs to be done. What we will do, we will take the questions and discussion later on once we have all the presentation. So now we will move to the next presentation by Kunal Keshri, and he will be talking about the migration and migrant question, which was, you can say, that was the defining feature of the first wave. So let's go to Kunal for presentation. Kunal, are you ready?
Am I audible?
Yes.
Thanks. First, let me share my screen. So, is it visible?
Yes, fine.
Yeah. So, first of all, I would like to thank IMPRI, directors Dr. Arjun Kumar, moderator Dr. Devender Singh, for inviting me to this prestigious lecture series. And I would like to say hello and welcome to our panelists, all the senior members, Professor Mala Ramanathan, Mala ma'am, hello, Dr. Srinivasan, Dr. Urvashi Prasad, Director, NITI Aayog. I would like to start my presentation from a brief note that migrants are a very important part of our society, our population, and they must be given their due consideration, their due respect, and they're not only in cities, but in whole country. So according to the theme given to me, I will be talking on population data and focusing on the internal migration. So briefly, I can say that pandemic, the word pandemic has come from Greek adjective, and its meaning is to incident to a whole people. So epidemic becomes pandemic, not only due to the number of people, but time and space it takes. What is the geographical coverage? It's very important to declare any endemic, epidemic, or disease to pandemic. And COVID-19 was declared as a pandemic by World Health Organization in March 2020, when it spread globally within 3 months of its first appearance at Wuhan, China. And then it spread like a wildfire. If we talk about the recorded history, so few of the notorious pandemics were the first plague. It came around 540 to 550 Common Era. It was also known as bubonic plague, and it really devastated the Byzantine Empire, which was mostly known as the Eastern Roman Empire. The second plague came in 1346 too, and it was till 1353, and it was known as a Black Death. It ravaged Europe like anything, and it was also known as, due to its number of people died, rough estimate says that millions of people died, that as a great mortality. And if we talk about the recent evidences of pandemic, which are known, more well documented, and Chinmay Tumbe has written a book on this, so I'm quoting him. So during 1817 to 1920, cholera killed around 20 million people worldwide. In the same period, plague claimed almost 13 million lives. And the deadliest pandemic, why it is called deadliest? Because you can see the number of people killed, 20 million in a short period of 1918 to 1920. And its repetition is maybe we can say in terms of the current COVID-19. So a pandemic affects millions of people and sometimes ravages civilizations. So preparedness is of utmost importance. COVID-19, which is having a devastating impact on the humankind for more than 2 years, is yet to be controlled. And till that means recent estimate of WHO show that we have 304 million confirmed cases worldwide and around 5.4 million deaths have occurred till date. And India is one of the second largest country in the world. It has also almost 36 million people have been confirmed as a COVID patient, maybe once, seconds, or 3 times. And around 500,000 deaths have occurred till death, roughly. Yeah, and people, experts say, epidemiologists say that peak of the third wave is yet to come. So what comes in future, it's a very dangerous. It may be very dangerous if we are not taking care of this. So now to enhance understanding of a situation like pandemic, we need to have a data, as Professor Ramanathan have told that we need a data, population data in different aspects, whether mortality or fertility, different dimension like age, sex, geographic area, geographic coverage, education, ethnicity, or any population subgroup. So COVID-19 has affected older adults, so they have been given more priority in vaccination and all the hospitalization. So similarly, a group of population, migrants, which have been directly or indirectly affected by COVID-19 globally, whether due to the loss of jobs in Gulf areas or lockdown of the Western countries like European countries. So different kinds of, not only by the contagions or by infections these have been affected, but side effects of these are very important to learn and understand. So along with the overall number of migrants, we always are, how many migrants are there? So it is important, but the composition or heterogeneity of migrants is equally important to be considered when we talk about the preparedness of the pandemic. And we failed really 2 years or 1 year back during this, when lockdowns were imposed or lockdown was implemented. So generally, in contrast to common belief that migrants are a homogeneous group, we first have to understand that migrants are not a common homogeneous group, and all the migrants are not same or equal. There is a hierarchy of migrants. So migrants in India can be classified in 2 groups: permanent migrants, which are more settled migrants, well-to-do migrants, and well-off group, and then the short-term or temporary migrants, temporary labor migrants. So the short-term or temporary and circulatory migrants, they keep shuttling between rural and urban areas in search of livelihood, and they belong to poor section of rural society, who also happen to be mostly the scheduled tribes, scheduled caste, and minority communities. The outbreak of pandemic COVID-19 and post-lockdown migration crisis in India has really highlighted the poor understanding of government agencies, which till recently has no clue of the real number of migrants and migrant labor staying in different mega cities of the country, or even different capital cities of the country. So during the time of COVID-19 and lockdown period, the temporary and circulatory migrants were badly affected due to their precarious jobs and informal sectors. So now I will talk about migration data in India briefly and give some idea about how many migrants were really affected from earlier data and whatever data we have. So data on migration in India is collected through the following sources of Government of India. First is the Census of India, about Professor Ramanathan has discussed briefly, and then we have National Sample Survey Organization. Now it is under Statistical Organization and CSO. So census usually have direct questions on migration to place of birth, place of last residence, duration of residence in the place of enumeration, place of residence on a specific date before the census. Indian census also collect information on permanent immigrant, means de facto census. However, it lacks information on the temporary or short-term migration. There is no information on out migrants. So latest available data from census is of 2011, which data was released very late. I think I remember it was released in 2018 and 19, and we started making some analysis on that. So this data should have been released earlier, then we could have better idea of migrant population. So then National Sample Survey Office, that comes under Ministry of Statistics and Program Implementation. It is the other major source of migration statistics, which is collecting migration data from last, I think 40 to 50 years, and collects information on internal as well as international migration, out migrants and remittances, household migration, return migrants, and temporary labor migration. Though the NSSO used to collect migration data every 7-8 years, but unfortunately, the latest available migration data is of reference years 2007-8, 64th round of NSSO. So after that, no detailed data on migration has been collected. We have other sources of government sources of migration. We can say National Family Health Survey also have few questions of place of last residence and place of years lived in the current place of residence, and whether you have changed your place. But it cannot be used as a major source because mostly is a truncated data, and it has an age limitation. We don't have a complete data of all the population. Also, the last year, Labour Bureau of India has begun some survey on migrant labor, but no data has been released till date. Hopefully, it may be in pipeline. One important source is India Human Development Survey. It is nationally representative survey which is conducted by University of Maryland, USA, and National Council of Applied Economic Research, India. It collected migration data in the last 2 rounds in 2004-5 and 2011-12. So it has a rich source of migration, but definition of migration, particularly permanent migration, is somehow not according to UN definition. And some critical information is missing, but it gives good information on out migrants, remittances, household migration, return migrants, and seasonal labor migration. So the latest data is still available for 2012. So we can say this is the latest data which we have, because census data, recent census has not been conducted, and it will come after 5-6 years. So we have to depend on this 2012 wala data, and 2007-8 NSSO data, and 2011 national sample census data. We have also some good research institutes like Center for Development Studies Thiruvananthapuram, and International Institute for Population Sciences Mumbai, that is also an institute of Ministry of Health. They keep on conducting some regional levels migrations data through some migration surveys in the states like Kerala, Goa, Gujarat, Uttar Pradesh, and Bihar. So we have some series of data for this. Now, I'm giving a brief glimpse of number of migrants. So according to census, which gives mostly the permanent migration data. So we had, if in terms of numbers, we had 225 million migrants. 1991, 2001, it was 307 million migrants. Internal migrants, and 2011 it was 447.1. If you add Kashmir, it will be 449.9. And if you talk about intercensal migrants, like these are the lifetime migrants, internal migrants, and intercensal migrants are the last 10 years migrants who have changed their place of residence from this census, which 2011 to between 2011 and 2001 and 11. So this figure is also not small, very big. So we have 13.9 million migrants according to 2011 population census, and percentage of migrants is increasing really. Lifetime migrants 26.9 to 30.2, and then it has become 37.3 in 2011. And percentage of intercensal migrant has also changed. increased from 9.7 in 91 to 9.5 in 2001 and almost 12% in 2011. So this is all about the permanent migrants. And if you talk about the rural-urban composition, male-female, so females have very high proportion of migration, mostly due to 80 or 90% of female migrate to their villages or their districts only, and short duration migration is there, short distance migration is there due to marriage migration. But male migration, majority of male migration is due to employment. Now, we can see the bilateral flow of migrants from this diagram. This can show that labor migrants migrated during 2007-8 period. And these are the last 10 years of migrants, 0 to 9 years of migrants. So major migrant sending states are like in purple color, UP. UP is sending migrants to all over Delhi, Maharashtra, then Gujarat. Bihar is the second important sending state, like Delhi is the main receiver for that. It is also, people are also going to Punjab. People are also going to Haryana, some are in Gujarat. So this kind of migration flow is there, but this is only for labor migrants, and millions of people are migrating to other states. Now coming to the estimates related to temporary labor migrant, I have prepared 2 columns using National Sample Survey data of 2007-8, which is the latest one for NSS data or CSO data. So estimated number we can have, it's 13.6 million. And if we talk about the states which have a largest number of migrants, Bihar, it's 2.1 million and UP 1.9 million. If we talk about the estimated number of out-of-state migrants, so out-of-state migration was very, very of concern because during COVID-19 lockdowns, these were the mostly affected and they had to travel really hard using whatever means they got, or by walking, or hundreds and thousands of kilometers. So in this aspect also, Bihar and UP have lead in this number of migrants. Also, Jharkhand, Madhya Pradesh, and Rajasthan have a large number of temporary migrants. So these migrants are of more concern because these are temporary migrants. They don't have a permanent work over in their destination state. They don't have any particular formal job. They are mostly dependent on informal jobs. They are radio wala, they are our rickshaw wala, they are auto wala. So these kind of migrants are affected very quickly. Even there is a 5 days or 6 days of lockdown. Like in Delhi, now kind of semi-lockdown situation is there. And yesterday I have read newspapers from Gurgaon and NCR region. This kind of migrants are again migrating to their place of origins. Also, I have tried from this data to check the hotspots of migration. So which are the sending regions of migration? So one region is very prominent in the southern region of Rajasthan and southeastern region of Gujarat. So these have a lot of concentration of temporary labor migrants. So I hope I have at least 2-3 minutes because
yes.
Okay, fine. So this region is very important because when return migration took place, I will show again other figure from government. So it is corresponding to my estimated data of migrants. So southern region of Rajasthan and southern region of Gujarat is prominent for sending migrants to these regions like Delhi or even internally to Ahmedabad and Mumbai. Then southern region of Uttar Pradesh, Vindhyan, and southern regions of Madhya Pradesh. This central region is very big hotspot of migrant. Then northern and southern regions of Bihar and northern region of Jharkhand, that is also known as the Hazaribagh Plateau. It is I think largest hotspot in terms of number of migrants, which even recently I have conducted during this gap of 2 waves of COVID in Jharkhand. So I found that these areas are filled up with temporary labor migrants. And I have seen the buses daily. One bus used to go from a very small village of Jharkhand that is called Jori to the Ahmedabad, to Surat, to Delhi, and people have agents there, means bus contractors, and they used to fill these buses with laborers with their consent, and sometimes with their choice, by giving some advance money to these places. Even just after I began my field survey, just before the second wave, and unfortunately my team and me was also contracting with COVID during Holi, then I had to stop my survey. So these regions are most important centers of temporary migrants. Odisha and Nagaland are also some bigger centers, hotspots of migrants. So when we talk about the data released by Ministry of Skill Development and other government sources, well, mostly I've used the newspaper articles. So by end of July, when lockdown was partially removed, relaxed, so Bihar 32 districts have shown the returned migrants number as 23.6 lakh, Uttar Pradesh 17.48 lakhs, Rajasthan 12.9 lakh, Madhya Pradesh 10.72 lakhs, Odisha 2.9 lakh, and it is a one source, Jharkhand 1.1 lakh. And these are typically the temporary migrants, because during lockdown or at the time of crunch situation, tough situation, these are forced to leave. They had to leave anyhow. So other source shows that total number of migrants returned in Bihar 30 lakh, and total skill mapping have been done by government, and total migrants labor returned to Jharkhand was 5.5 lakhs, and Uttar Pradesh highest number of migrant returned 32 lakh. So these figures are very not complete, because whatever estimate I have shown earlier number, so these are older estimates. So the figure may be of twice of that. All migrants are not vulnerable. I am also a migrant, permanent migrant. So I'm not that vulnerable. I have a regular job. But migrants who have informal jobs, who are staying in some city for last 2-3 years, but they keep on shuttling between rural and urban areas, their destination and origin. So these are the most vulnerable migrants which are affected by the lockdowns. So now coming to one very important survey which we have conducted after second wave. As I told that I had to stop my survey in the last year, March and April, during the beginning of second wave. So again, I got a chance to collaborate with some international agencies and university to do a survey in UP. I was the PI for UP, and in Bihar, some team members have done, and Delhi, some team members have done survey. So more than 600 migrant households were interviewed, and 150 non-migrant households were interviewed, and more than 50 qualitative interviews with migrant workers have been conducted. So our brief findings, it is not complete finding because we are still in primary analysis phase. So loss of employment was experienced by majority of them, and we found a significant increase in moderate and severe food insecurity of these groups, because our focus was to understand the employment, food insecurity, and related aspects of migrants, which really affected their life post second wave. And dietary diversity also worsened post national lockdown in all the states. So just I want to say that there is a paucity of migration data. Latest data we have of 2012 IHDS data, that is also not very, we can say, complete data of migration. Census data gives a very good result, good estimate, but it lacks information on temporary migrants. NSS data, now CSO, it used to give a good estimate of temporary labor migrants, and its coverage was also good, but now it is not conducting any survey till as per my knowledge. So just we need to have some good data. We need a good data to do good analysis, to give some good idea about the problems of the migrants or any situation, whether it's a pandemic situation, any disaster situation, or any job loss. So now I am stopping my presentation, ending my presentation, and thanks to everyone for patient listening. I'm open for questions and discussion. Thank you so much.
Thank you, Kunal.
Thank you.
Now I'll request Venkatesh sir to make presentation. Now, just now we listened to the vulnerable group, Migrant, and other equally affected group was the elderly people. So in the next presentation, Venkatesh sir will focus on the elderly group, aging.
Thanks to my friend Devender and my former colleague, Dr. Arjun, and colleagues at IMPRI. It's thoughtful of you to have set up a platform for practitioners, professionals to come and share their thoughts on preparedness for the pandemic. I will focus on a very small subset, but an important subset of the population, important group of people who are affected by the pandemic. And my thoughts again are not limited just to the pandemic, but as a group, how this group of the aged 60 plus will have to be catered to in the future. I understand that there are, next slide. I understand that there are younger people in the attending this panel discussion. Arjun, can you next slide, please? Yeah. So what I'll do is I'll quickly take you through. This is the first part is not for those who already know about the situation of the elderly in India, but for those who are students and who would want to get more information on the status of the elderly in India. And then I'll move on to the issues of what data we have, what we do not have, and what is the strength of the data that we have for policy formulation and programmatic responses. And if there aren't relevant data that are available but are not on a timely basis, what is it that we should probably be doing? So you would have heard Professor Mala and our young friend Kesari, who have talked about the issues with migration and the other data sets that are available that Dr. Professor Mala shared. So let me then start with what is the issue of the aged or the elderly population in this country? Is this a matter of concern? Next slide, please. So as you would see in the coming slide or in this slide, see the problem with India is that we are, okay, one of the parameters for knowing as to what is the scenario on the aged is to look at the doubling time. In how many years a country will have doubled the population of the 60 plus? For this, you will see from the slide that it has taken about 110 years for France to double and about 80 years for Sweden to have doubled. So, it means between 1860 and 1980, 110 years almost, 1870 to 1980. So that's the time that it has probably taken for France to double its population. But when it comes to India and China, China in 25 years and India in 20 years. So that's the biggest challenge that we have. So by about 2030, 2035, we are going to have double the population that we had in 2011. So that's the seriousness that we need to accord to the aged and therefore think of what policies and programs are critical. And while one thing that this type of macro data will tell you that yes, it's a big problem. So what do we do with it? This type of data, we need to have more specific data so that we're able to plan our policies. Next slide, please. So there again, as you would see, that India is not one. It's a set of states which are at different levels of demographic transition. So you would see with India in the middle. 2011 population 8.6% 60 plus. By 2041, this will become 15.9 national averages. But when you see states like Kerala or Tamil Nadu for that matter even, you will see that it's around 22-23%. So anything about 20% population is called as an aging country or aging state for that matter, for India, let's say. So, but then again, you have a Bihar, which will hardly have, 11% population, which probably is the national average by the 2021 census. So even in another 20 years, they'll still be, far behind. But then each state has some level of 60 plus population at any point of time, which will naturally be there. So what is the planning that has to take place for the services for these people, and what is the databases that are available? Before moving to the database, what are the vulnerabilities for which we need to plan? Next, please. The vulnerabilities are quite high. The vulnerabilities related to economic, conditions, to health conditions, to the social issues of gender and so on. I'll talk about a few. This is not a presentation on the elderly, so I wouldn't want to get into details. But just to give a flavor to the young participants in who are hearing to this panel and to my presentation. So only 30% of the elderly are dependent by or self-dependent economically, or 70% are dependent on others, either fully dependent or partially dependent. This is a very alarming situation, in this country, and needs a big social sector response. And the current response, though, we can say that there is a response to every issue of the aged, the response measure is quite small. So we need to look at the issues, not for the present, but for the next 20-30 years. The scenario is not going to majorly change. One other thing, for a country like the European countries or the developed countries, the scenario was different. When they started aging, they also became economically better off. Whereas in India, it's not going to be that scenario. Maybe China to some extent, because their per capita income is quite high. But for India, it is quite low, and it's not going to be majorly there will be improvements. There is no two thoughts about it, but not going to be majorly changing to cover the entire population. So there will definitely be people below the poverty line for for some decades. The workforce, which again is a major contributor to the economical to the socioeconomic background of any poor. 90% of the workforce is in the informal sector. So the savings is very poor, and the social protection, that one could have from their, savings is going to be meager in the old age. Then even in the formal sectors, which is less than 10%, I suppose, is the lack of preparation among the aged for the future. For post-retirement, that preparedness is quite low. That's why you will see nowadays that there are a lot of advertisements being, put up by the government and less by the government, but other insurance companies asking the young people to start looking at the annuities and pension, 30 years from now when they start retiring and so on. So that type of a thing is very important because the preparation for the retirement is quite poor. And this gets aggravated, especially when people are going to become more nuclear, in their families without much support from others, from the next generation. The interesting thing, I think, the earlier two presenters talked about the workforce. I did a small analysis, I think last year, starting last year, around the same time, on Manrega. So why I'm showing this is that the population of 60 plus is, as I said, about 8.69%, 10%. But whereas when you get to the people who have registered for Manrega was about 14%, so 1.5 times. So what it means is that there is huge amount of economic need among the elderly, and they want to work. And this also comes out through studies that my former organization UNFPA had also conducted. And this is the data from the government is also consistent. So then similarly, the registration of Manrega for even 80 plus, which is very unfortunate that such old people in this country are working. So just to set out a scenario on the economic conditions of the elderly, and then therefore I'll argue as to what is the need for the data for the interventions. Next slide, please. So when we look at the issues of health and gender concerns, we all know that increasing life expectancy brings in a lot of morbidities, and the disease burden among the 60 plus is definitely going to be high. But 30% of all the 60 plus to 60 to 80 79-year population have acute morbidities, and 80 plus population have almost 40% of them have these morbidities. The worst part of this is that women are more afflicted. Morbidities are more, but hospitalization rates, because of the poor status of women in our societies, they are not hospitalized, whereas the men are better treated and they are taken to hospitals and so on. Then 10%, some studies talk of a bit higher averages of higher percentages of people needing support for active activities of daily living. So this is a area where we need data, so that any support, whether in terms of equipment or other support that's needed at the community level, how much of that has to be provided for, and what provisions does a policymaker have to provide for. So these are the type of estimates that will, the data that will help in estimating. So therefore, activities of daily living is an issue for the elderly. Then abuse. The fact is that the elder abuse is high, with women suffering more. So what it means is the men also are suffering, being beaten up, or ill-treated. Beaten up is the last, resort. But there is a lot of negligence on part of the families in not speaking to them. They might even provide food, but not speaking to them, not socializing with them, and so on, which is a major concern, which leads to mental disabilities, mental health problems, which needs to be also factored in if we are looking at services for the aged. Next, please. Here, if you look at it, if you look at the need for the assistance for daily needs, currently, let us say 7.6%, and by 2050, 25% of the 60 plus population are going to need this type of assistance. So how do we prepare ourselves? So for attending to these needs that are only going to be increasing, because we are going to be an aged population, and these demands will only rise, and it's not going to go down. So it's not like fertility. Fertility can go down, but the people on this in this land are going to stay here, and you're going to find more morbidities that needs to be attended to. Next. So therefore, what is the data that is available for planning for services? As both the speakers earlier talked of, the longitudinal aging study in India, and there are a few others as well, but all micro studies. But this longitudinal aging study is one of the bigger sampled studies that has been commissioned. And what does it provide? It provides data on the health burden and the risk factors, the healthcare seeking behaviors and healthcare financing by the individuals, how much is out of pocket expenses, and so on. Then on social issues related to whether people stay in their families or they are single, what are the social networks, how are they benefiting from social welfare programs, and so on. That data is also available, which is a good wealth of data. On the economic front, income that related data is there. Again, as I said, this is all sample basis, but still it is quite a large sample, and one can use them for policy purposes. So wealth, whether they have wealth to fall back upon, if there is a high incidence of medical problems that they have, will they go into indebtedness, and so on, can be is available. Then expenditure patterns, then employment, then retirement and pension. data is available from this survey. This again is a good thing that has been undertaken for this particular group of 60 plus in this country. And it is good to also benchmark, such with this, this data set with other country data set, let's say of Charles, Charles is a study from China or from other country data sets. So how we are doing and so on. So this helps in policy formulation. So what does it mean? It would, let us say, in this pandemic. In this pandemic, we are trying to provide for nutritional, support. So the nutritional support, you can do some calculation based on this to say that so many people are above 60, or we do a cutoff at 70 plus are more needy, and this is the nutritional status, and this is the economic status, and we triangulate these things and find out that how many people are really in need. So that type of estimation of the populations for providing nutritional support in a pandemic is possible. But the challenge is that only helps you give you a budget, that you can earmark as a finance minister or the finance ministry. But beyond that, at the state level, how do you plan state and most importantly, the sub-district levels? Whom are you going to target? So I'll come to that. So the targeting of individuals to seek to provide for services is the most critical. And this is where most of our programs fail badly, and there is misproportionate distribution of resources where it is not needed. You provide them where it is needed, you don't have. So that is where more precise planning of services for social services, security services, nutritional security, or health services, start faltering when it comes to the agent. The other aspect of aging services for the aging is that there is no agency or no department at the state level which looks at the aged in a comprehensive manner. The health looks at certain health services. Beyond that, there isn't anyone. Why? Because the Department of Social Welfare does not have an outreach at the village level. So it doesn't mean that every department will have to have its own human resources. That's what I will argue a bit later, how we can use the currently available resources to collect data. But I'm just giving you the scenario as to how complicated it is to deliver services, to the aged, for the aged, and most importantly, the lack of data. One can only say that yes, the rural development does it, but the rural development does not have data. So let's be clear that they do not have the precise data and be able to target in a very objective manner. Yeah, next please. Okay. For social service provision, I will talk of the health sector response. The health sector response for data, not only on the aged but for the entire population. There is this has been this talk of having electronic medical record or health records for quite a long time. Now, even the policy paper, even in the Ministry of Health, was in 2014, 7-8 years back, and there have been attempts both by the government and NGOs, but very, very small scale. But we haven't really. But now that the National Health Authority has reinvigorated in this whole thing, it is good. But how is it helpful? These records are mostly for the health services, being provided. It is a good record of the health history and to record the service that is being, provided. But the preventive aspects, the current status, those things are not captured in these type of electronic, medical and health records. It has to be, thought of very differently. Not very, very differently, but I will argue from literature and experience, from other countries, that there could be an electronic record, but have modules for service provision at the periphery, at the tertiary level, and at the tertiary level, and at the village level. You can have a module to collect data on the different health aspects. I'll come to the other areas which need data, and for that also this electronic record can be modified in today's age of IT. Hopefully in a few years, we'll have a good amount of penetration in, I think, a couple of years probably, that we'll have good internet, connectivity and uploading of data right from the village level itself. So there is this very high probability of collecting such data, but currently we don't have a system. That's my argument here. Next, please. Okay, as I said, what is the most important challenge? The most important challenge is to find out who needs what service at the village level. So I am saying that we need to think of an elder data record system. I just gave it a term, recording system, let's say, and it should be integrated. It should be integrated so that we are able to provide day-to-day services like health services, like services for the pensions that are available, the pension schemes that are there. So these are services, if not on a day-to-day basis, but at least on a monthly basis. So there has to be a data set which will help in these in the provision or targeting of the services. Let's say if there is any nutritional scheme, so who's going to get this food in this village? We currently do not have much of a BPL cards. All of them are pulled together, fine. But how many exactly are there? Those data is not there, and therefore I am arguing that we need to have an integrated elder data recording system. Then how do we collect this data? So you don't have to have surveys of a small sample are done for research purposes, but for programs you need to come up with a solution which is maybe 60% perfect, 70% perfect, 80% perfect, depends on the state's governance also. But you need to have a system where you can gather data on scale. So that's why I'm arguing that for those people who have gray hair like me would know that when we started the health program, it was all focused on fertility and mortality. Mortality what? Mortality of infant mortality and maternal mortality. So all our records that are there stop with recording recording data on individuals so on till 49. That's the major focus. Now there is focus a bit on national non-communicable diseases, but not much. But in those times, there was not those times, even if I think about 5-7 years back, also 10 years back, also there was this eligible couple survey. So now that the country has almost achieved fertility objectives, we need to now reposition ourselves. This country will have to think seriously of repositioning itself. I was reading when Devender asked me to be on this panel, I thought that it's important to see what happened in other countries. Even as late as 2017-18, there was a policy paper, very good, interesting paper from UK, talking of the effectiveness of national health services and other social services that they are providing and how they need to see this in the next 30-year time span. So, but whereas in India, we are not looking at these type of things. So we need to look at how elders are going to be, serviced. And therefore, reposition, as what I'm coming to is that repositioning activities like the eligible couple survey to a family survey, which can be updated, which can be done every year at the start of the year. Let's say April, May, you can devote for every health worker to do it. And I can assure you that the data collection will not be a problem, because we all know the type of enumerators that are enlisted for the big surveys, what background they come from. Except the training the ANMs need, they have better skills, the health workers, to collect this type of data, and it can be undertaken, and it can focus on physical, mental health, very, very brief. It didn't have to get into the details, because this is not a cause of death survey or anything just to be done by medical professionals. This is trying to get a sense of, the physical health, the mental health, their housing, the socialization in terms of whether they are staying alone or with others. And most important thing is that this survey being a survey which looks at a bit broader than the health, interoperability of this database is critical. This country cannot, have each department go and commission studies. This is not the way we should think of community, level, data, especially the MIS data, from the system generated, data. It has all flaws. We all agree. We know that, but that's a data set which should be available, and it should be available for different departments to access it for their own planning. So as I was saying, planning for, targeting of nutrition supplements, or, for medical, definitely for, housing that might be given preference for elderly, or even skill development, which you would know from the physical condition of the elderly and so on. So for everything there, every department, whatever data they need, for that they should be able to access this data set, and it should be available, and it should be interoperable. Everyone can use this database, whichever department, and this is the way to probably go about it, which then the topic of today is pandemics. If such a database was there, we wouldn't have been so let down. Currently, we do not have any estimate of the elderly, where they are, where they are probably we know, but what is the status, the elderly deaths, if it is recorded. Now, Professor Mala was talking of the census, SRS, and so on. So the data that you get is after 5-6 years. Even Keshav was talking of. So these are all data which comes quite late. So whatever rough and dirty data that you can get, from a system that I am talking of, if only this was in place a few years back, we could have been in a better position. I think this is the last year. Next slide, please. Yeah. So this is what I wanted to share, with especially with the young friends, who are part of this presentation. Would love to have questions. So I am a practitioner, so my thoughts are always in terms of how policies and programs could benefit from data or lack of data, and how we need to position ourselves to get better data, so that our policies and programs are more targeted and more focused. Thank you. Thanks to IMPRI for having me here. Thank you.
Thank you, sir. We are running a little late on the schedule, so I will not waste much time and request Urvashi ji to share her thoughts.
Thank you. We've already had very detailed presentations, so I'll keep my remarks brief. So firstly, I think this is a very, very important topic, obviously, absolutely critical, especially from the policy making perspective. This is a challenge that we deal with on an everyday basis. Now, we're talking of data and pandemic preparedness. I think, it's very clear that we can be prepared well for such a situation if our data systems on a regular basis are functioning as we would want them to, and addressing a lot of the questions that have been raised in the presentation. So I will speak specifically, on health sector data and related data. Now, there's a lot of challenges that we face with this data on an ongoing basis, whether or not we are in a pandemic situation. One is obviously the fragmentation, and that was also spoken about, that even within the health sector data, there's a lot of fragmentation. There's different systems where different data is being collected, and a lot of these necessarily don't talk to each other. And it's also often difficult to trace a single beneficiary or a single individual through these different data systems. So that is, of course, one challenge that we face on an ongoing level. To add to that is that, for those of us who have a public health background, as I do, it's not possible to make policies in public health by purely looking at health sector data. It is very important to look at data from a number of other related and linked sectors as well. And that is not very easy or conducive to do right now. Again, because of the multiple different sort of systems that disparate systems that we have. The identity I spoke about, through the system, how do you track a single individual? And this, of course, gets even more complicated when we are looking at the multiple levels of data collection and analysis, starting right at the sub-district, block levels or even below that, and then moving its way up through to the state, through to the center. So that becomes very, very challenging. And that is something that we need to address. And then, of course, there's a lot of other issues in terms of the actual collection of the data, standardized protocols for doing that. Even the different indicators we have, do they mean the same thing to everybody? Do they mean the same thing across states, across stakeholders? That is often also not the case. So these are a lot of the ongoing challenges that we face when we look at data pertaining to the health sector, and therefore we have tried to put in motion certain efforts over the last few years, and we're continuing to work on them to streamline some of this data, to address some of this fragmentation. The existing data sets, how can we actually use them better? So we have been working on a national data analytics platform, which actually seeks to do this, that, whatever existing data we have, firstly, how can we make best use of that? Because that itself is not necessarily happening. And by saying that, how do we make best use of it, it obviously means that it's also accessible to stakeholders outside the government, because they are the ones who can really do a lot of analytics on it, who can generate a lot of rich insights. So right from academics to civil society to private sector, anyone who really wants to do some meaningful analysis, how do we actually get this data to them in a way which is also obviously sensitive and is maintaining the security, the safety of the data, because that is another big challenge in the health sector, where consent and the ethical part becomes very, very important, because this is all very sensitive data if it is obviously revealed at an individual level. So that is one part of it, but a lot of the other part of the effort that we're doing is how do we actually strengthen our data collection, gathering and analysis mechanisms. And in this, we have some shorter term steps that we need to take, and a lot of those insights have also come from today's presentations. But we are also building up to a slightly medium to longer term vision, and this is something we articulated in the action agenda document as well that we had published, is that we do need to strengthen institutional capacity for data at the state levels, at the sub-state levels. We need to have an institution which can be tasked with collecting data, with analyzing it, with putting it out in the public domain on an ongoing basis, and do it in a sort of independent, objective manner, because this point was also raised that data can often get politicized, or everybody can sort of look at it from the lens that makes sense to them, and then there can be question marks around the veracity of the data. So we do believe that and of course this is something that wouldn't happen overnight, but we do need to work towards having such institutions, at least to begin with at the regional level, but then eventually at least at the state level, because as we know in India, states are more like countries. So we really cannot, just be having this sort of capacity at a union level or even a regional level. It does need to be much more granular than that. And then we have certain standardized protocols as per which this data is actually collected and analyzed and put out regularly in the public domain. So that is actually the broader vision that we are actually working towards, because this is one capacity that we feel needs to be strengthened significantly. We do have a lot of surveys that we do, and that is fine. We can, of course, continue to find ways and means to improve the periodicity of those surveys, their coverage, strengthen them in many different ways. But really, how do we move beyond these surveys as well and look at institutional capacity when we are talking of data collection analysis, as well as really putting it out on a regular basis. So that is something that we are very focused on. And one sort of final point I'll make quickly in the context of pandemics, because that is the immediate context and topic for this discussion, is that we also need to kind of write, at the beginning, if and when we ever have to face such situations. But I think it applies to other situations as well. It might not be only a pandemic, but any sort of crisis situation like this, where there are a lot of different stakeholders who immediately become interested in a particular set of data which is being put out. This pandemic has made everybody interested. Every citizen, everyone on social media, every single person out there is interested in this health data. Everybody has their views and comments and perspectives on the statistics. So and social media, as I said, WhatsApp, all of this, of course, means that these views, these opinions, they also travel very, very quickly. And while some of that is advantageous, there are also challenges and risks of some of this data or metrics being misinterpreted or not being looked at in the right way. So that is also something that I think is a learning. If I look back last year, because I have been involved in this entire COVID response, and part of the work I've been doing is analyzing the data every day. And I've, of course, tried to put it out on my social media handles and through whatever channels I had, apart from the official channels as well, was because there was a lot of confusion, naturally, so a lot of apprehension, and very, very small sort of things can go out of control very quickly. So I remember when we started last year, we would have these infographics which would go out on social media. I would often see them, which would basically say, okay, such and such state has the highest number of cases. And I used to again and again sort of correct that and say that, well, if that actually means they're testing, then that's probably a good thing. And this is how we need to look at these numbers. So I think that also is a very important piece, and I think an important learning, that the stakeholders, both within the government as well as experts outside, whenever there is a situation like that, to actually come together and at the outset set the tone for what are the key metrics, how should they be looked at, how should they be interpreted. Some of it happened in due course, but I think for the future, this could be a learning where this is done much more upfront, because that would reduce the sort of extent of misinformation or misinterpretation that might also go around. So I think that's a slightly different point, but I think it's a very, very important one all the same. So yeah, I'll stop here. Thank you very much for inviting me here. Thank you.
Thank you very much. What a nice way to kind of bring this the presentation to an end, and with the what government is doing, what is being done at the policy level, and some of the issues raised in different presentation would also got addressed. And I really liked one thing, that we cannot just focus on health indicators or health services when we are talking about pandemic preparedness as well as response. Other related factors our field also need to be integrated, and that's what we heard in Venkatesh's presentation as well as Kunal's presentation. And so nice way to bring to a close at the presentation level. Now we will open for question and answer and discussion. And Arjun, if you can tell me if there are questions from the participants, then we can start with those questions.
Right, sir. I will check in Facebook.
Okay. So if I can start with my own question in the meantime, when Arjun is looking for questions from the participants. One thing which is coming across that maybe it's a not a very fortunate situation that there is pandemic, and because of pandemic we have come to know that there are 2-3 things which came up in the presentation. That one is that we don't have adequate data. We don't have sufficient data. The second thing is that data which whatever data we have is not collected or updated very regularly. Third, there are serious quality issues, as Professor Ramanathan pointed out in SRS and CRS data. Quality issues are there, completeness issues are there, and also there are a lot of differentials across states. In that situation, and we are also seeing the kind of, I should not be saying turf fight, but who will do which survey? Like labor survey, it will be Labor Bureau, it will be NITI Aayog, or it will be NSSO. Who will do that survey? Ministry of Labor will do, Labor Bureau will do. NITI Aayog also took at one point of time that we will have a survey to find out the exact number of laborers, especially in relation. It came in the context of kind of reduction in women workforce participation. So there are several issues related to data. Now this, like census is also affected. We will not have census data, and because census data will not have SRS data, the panel will be affected. As Kunal also pointed out, on some issues we don't bother to come up with data. Like for example, 2011 census, the projections for the next 20 years, that team was not set up until 2020. On migration data, the panels were not released up to 2018. Correct me if I'm wrong, Kunal. So
yeah, you are right.
Dr. Singh, the data was released, not Kunal, in 2019. It was not even 18. It was released in sometime in September.
Small tables they have released, 1 or 2 Excel files by 18, and then in 19 they have released majority of them. Yes, you are right.
Analysis only 2019.
Yeah, you are right, ma'am.
Yeah. So that's like, are we serious about data? So one, as I was saying, that pandemic has opened our eyes that there is a serious need of data. We need to have data, different kinds of data at the population level as well as services, health services and other services level. We need to have that kind of data. So from the panelists, I want to ask, is this only the realization, or are there concrete steps which are being taken by the government to strengthen not only the quality but also availability and regularity of that data.
Yes, and sir, also there are not much questions on Facebook, some comments only. But let me ask one question. We also have now real-time data, as there is also, periodicity and lag in the data. For unorganized worker, we have e-shram. We have also the insurance data also, many from the health side also. How do we see going forward the use of this real-time data? Because administratively, this data is only being used. For example, we are giving PM Kisan to all the farmers. So we have more data, real-time data now. So how to go ahead with that also? What are the views of the panelists? So yes, Nala ma'am, over to you.
Yeah, the issue with most of these large-scale databases is the matching denominators. See, when we need to do relative tracking individuals for monitoring their health, this kind of data is okay. But when you need to look at investment, for instance, how much more money do we need to put in for vaccination in which state? A question of this kind calls for also the rates. And for that, we need valid denominators. In 2022, we cannot be talking about 2019 data. And that is, we have a system. The RGI's office census office used to have, this issue of getting our projections would not have been a problem if the Statistical Bureau of the Census had been retained and it continued to function. It was a regular exercise that we did, making projections and validating it in the intercensal period. I'll give you a small problem that we are going to face in all our future computations with population. Small issue. Every time 2011, 2021, 2031, 41, 51, 61, 2001, 2011. Every 10 years, we had an estimate. We divided the rates by 10 and got intercensal. Now, for any accurate estimates in future, when we do the census in 2022, we will need to retrospectively have the same figures for 2021 because a lot of our computation is incumbent upon that. Therefore, strengthening the statistical capacities and proactively, planning for this is an extremely important thing to do in the now if we have to learn. And that is a lesson, we can't let systems go off thinking that, on an ongoing, every time we think that our CRS is improving, we don't need SRS. Our SRS is improving, we don't need CRS. So we didn't bother about anything. It's time that, we bothered about everything. Not in silos, SRS, SRS, CRS, CRS. No, because each one, census feeds into SRS, SRS feeds into CRS. Everything is interrelated. If we don't realize that now, when are we going to? And it's not that these efforts are not ongoing. We need to, do it more urgently. It is something which, moves at a very phenomenal pace with 1.25 billion people. Things move slowly. We need to come out of that inertia now because that is the lesson the pandemic taught us. ये नहीं है कि कर नहीं सकते, मगर कब करेंगे? That becomes an issue. Now we have to do it with some degree of urgency. It is not that we are lacking in capacity. It is not that we are lacking in the will. We need to bring everything together. That's my take-home message.
Thank you, Malaji.
Yeah, quick response. I think Madam Urvashi, talked about. Madam Urvashi talked about the responses from the government. There, to me, having worked on the other side of the government for more than 3.5 decades, I can see the level of appreciation today in the government on lack of data. You can also see, certain political statements that we don't have data, we need to do that. But having said that, there has to be immediate response in terms of revising our, statistical, system, not the, data gathering system, but the whole structural, let's say the Ministry of, MOSPI. How is it currently structured? Whether it has teams to look at in an integrated manner, different data sets for different groups. That type of thinking is, important. I also understand from my colleagues in the statistical services, many of them have retired, that the Statistical Commission had a lot of very, very good, suggestions, but unfortunately, not much of them have, been made into a reality. Yes, Professor Mala's, lament or, great concern, I would say, on the non-functional, parts of the census is something very critical. And that is something that we cannot, be a developing country or a developed country in another 5 years or whatever targets we want to set without data. That is something that has to be seriously taken, through. And I hope, the current political dispensation also puts in efforts beyond, the thought processes that are there to see that, these things improve. And institutions like NITI, should probably, lay out a very strong, map on how we are going to position ourselves with almost like 6 monthly or annual targets as to what is it that we are going to achieve in terms of repositioning, our organizations that are working on data over the years, and also the role of the statistical institutions. To me, I said I'm a practitioner, but I'm not a practitioner from that point of view, but on the side of practice, I've been engaged. And I don't see, the link between, the academic and, the policymakers that strongly. That also needs to be, looked at and promoted. Not that, they might not want to be part of it, but there has to be, from this side also, the practitioner side also to engage. Let me stop here. I think it's quite a, long, debate that we have had. Thank you.
Urvashi ji, you want to add? Kunal, you want to add something?
Yeah, I am also in support of integration of data. Like if we are collecting some data for some purpose, so different organizations should not collect differently. So there should be a common objective of government data sources. If we are collecting like in NFHS, most of the things have been covered now. DLHS has different objectives, but AHS and other, so there is some sort of integration is going on. So similarly in socioeconomic data, we have NSS, CSO, they are doing their own job. So migration also needs some special focus, particularly even if NFHS is collecting some data on migration. So it should give some more emphasis on some basic questions of migration. If NSS is not doing that survey, then census could have improved something like temporary migration, or this kind of information should be collected in census also. So that different agencies should not be involved in same exercise. Otherwise, integration or synchronization of data is, I think, need of the time. Thank you.
There is what Arjun was hinting at, that there is this large data coming from census or NSSO or from different survey. But there is big data also, real-time data, which he said, which could be with the ministries, with different programs, and which NITI Aayog is keeping a close tab also because of monitoring of the Sustainable Development Goal on different indicators. So how we can use that real-time data or the programmatic data which ministries are collecting, with NITI Aayog is also keeping a tab on that, how that could be marshaled in a situation like this, when we may not have a very regular data, like data is very old, but there are other sources of data, how we can use that.
Madam Urvashi was opening her mic,
Okay.
Devender, for her comments probably. I'll just say one thing. Countries like South Korea are not doing census the way we are doing. Devender, you would recollect when we had this, team from South Korea, they shared with us that administrative records are becoming the basis in developed countries. So I think we need to have a roadmap as to how are we going to do the 2031 census, or maybe 2031 census, let's say, or 2041 census. At least by then we should have strong administrative records. So that's the way forward. Maybe, Devender, you might request Madam Urvashi. I think she was.
Urvashi, yeah.
Yeah, no, I was just adding like a couple of very quick points. So no, I absolutely agree. I think all points are very, very valid and very well taken. In fact, I think, you mentioned SDGs, and that is actually one of the, given that NITI is sort of tasked with the overall sort of implementation of that, one of the things we are doing is trying to use that as a channel to then actually engage with states, because what has happened is with the whole change and transition from Planning Commission to NITI Aayog, a lot of the state planning departments are also looking for and in need of a sort of new and re-energized role. And one of the things that we're trying to bring in there is the data aspect, because, like I mentioned and others have also emphasized, that this is not something we can think of as just, piecemeal approach or a few surveys here and there. This needs a strong institutional capacity on an ongoing basis. And so that we are looking at that, can we make some inroads through the state planning departments and, get into the states using this. I mean, while we're talking of SDGs, but ultimately data is what underpins all of that. So that is actually one of the channels that we're trying to use, even as I speak, and as we're engaging with a lot of state departments on that. So I think that is something that I think we should take forward in a very, very sort of concerted way. And I think just, this is something I wanted to mention in the beginning, but I think it then came up subsequently, that it is actually very complex in terms of so like you mentioned, real-time data, administrative data, and then of course we have more longer term data that comes out. But also I think especially in a sector like health, where there is so much of data which actually lies outside the government, tapping into that, because a lot of people are actually going for health services outside the government system, and not all of it would be in a large, corporatized hospital. I mean, people might be going to a 2-bedded, 3-bedded, smaller establishment. So there's data residing in all of those. And I think that's also a big piece of the challenge for us, is how to actually aggregate this data, get it together from all the different types of stakeholders and service providers that actually exist. And I think in health, we see a lot of diversity, and it would be true in other sectors also. So how do we actually do that? It's again, it's not a new question, but it's a very, very challenging one for us, because otherwise a lot of the data we might be seeing might only be actually a very small piece of it, whereas a lot of the other data would be actually outside the government system. So I think that is just to add on to that I think that's another very important and challenging element that we're trying to look at. Yeah, that's all from me. Thank you.
Urvashi, if I may quickly ask you, you mentioned something on National Data Analytics Platform.
Yes.
Can you elucidate a little bit for the information of our participants? What it is? And
Yeah. So this is something that, it's been in the works the last few years, but now it has sort of picked up a lot more momentum in recently, and we're actually hoping that it should be launched also quite soon for the public as well. So I think here the main idea is that we have picked up certain sectors, health is there, various other sectors are there, where we are actually trying to look at whatever is currently existing, and whatever, so as I said, we have so many different types of metrics, indicators which are currently existing, but they are not necessarily being all pieced together and analyzed in a way that we can derive fully meaningful information from them. So that is, I would say, the overarching sort of goal of this exercise. So this by itself is not expected to address all our issues, but this is more to look at existing data, whatever we have available, actually cleaning that up, putting that out in a meaningful way for anybody to look at. So this is data which will be in the public domain. This is not just for government, but this is meant to be for everybody outside the government system as well, to be able to say that in a particular sector, if I want to look at a bunch of indicators, how are those moving and what has been the trajectory and what are the insights we can actually get from the currently available data systems. So that is sort of the first step that we are taking with this national data analytics platform. So that's why I said the focus here is much more on making data accessible and focusing on the analytics part. But it is also going to then obviously logically move on to looking at the actual type of data being collected and the quality and so on and so forth. So that is really the sort of initiative in a nutshell.
Thank you. And that answer are Arjun's and my question both, like how the large data as well as big data are the real-time data, are the administrative data, which Venkatesh sir also mentioned, how that could be brought together. I hope that this analytics platform that will be a good place to bring all data set together, clean them, and how best they can be used to assess the progress on different indicators, and not only in the context of sustainable development goal, but overall development goal of the country. I think let's see how it progresses. If there are no other questions from like panel discussion among themselves, if they want to ask anything, or from Arjun, then
if any panelists want to add anything, or we can go to a way forward round also.
Way forward, this was the way forward.
Okay.
Yeah.
So maybe, sir, you can summarize, followed by your vote of thanks.
Okay. So as I was pointing out that a few things came up. Importance of Arjun, you want to do? Sorry.
No, sir. Please go ahead.
Okay. No, I think you shared the page. That's why I thought. So few things came up. Data, importance of data has been recognized by all the panelists, and in areas more than health, but the morbidity data, mortality data, the data sources which are being provided, that migration has been exclusively we have discussed, as well as aging. So there is an urgent need of regular, high quality and complete data that has been recognized, and whether it's long-standing concerns or demand of the data users, or it came out more with a heightened focus during the pandemic, but this demand has come back on the platform that we need to have good data. Then second thing, that there are different data sources. How we best can use while we keep on trying to strengthen the data sources and improve the quality of the data, there are other data sources, how we can harness or mine the data from those sources, like administrative records or services and programs data, how that can be brought together. Like, for example, migration, if the survey is not taking place, so what are the alternative sources of data apart from the small studies which are being conducted? Could the e-shram data, could that become a source of data on migration? So we need to think of imaginative alternative ways how we can have data till the time that we have regular surveys, or we have better quality data from the nationally representative samples or from census. That was another point. Then when we were thinking of this this topic, the population data and pandemic preparedness, what we were also thinking that it is not only when the pandemic is happening or after the pandemic, how we can use the population data. But there are 3 stages of the pandemic, and in each stage, how we can use the population data. Like the first is how to prepare or predict the pandemic. What kind of data, population data, can be used at that? And Professor Ramanathan stressed on the importance of denominators, are the estimates at the local level of the data. If we have good projections or estimates and forecasting of the population based on census, we know what kind of population, vulnerable population, living in which areas. Could that be used to predict the behavior of the, not only predict the behavior, but also how it's going to impact different population groups? What kind of mother and child requirements are there in a particular society? What kind of aging population is there? As Mr. Venkatesh Srinivasan was saying, that it's not going to be same in different states. Like Kerala is pretty different than Bihar. So how we can use this kind of data to plan for the epidemic. Like for example, when the first wave, when the pandemic started, we did not include the family planning services as part of essential services. Did we not know that this is a emergency services? We cannot stop the birth or services for the elderly people, that they will require the not only medical attention but also services related to which are terminal diseases. So, but those were stopped. Only focus was on the containing the pandemic. This kind of use of population data can be helpful in preparing for these services. Similarly, when lockdown happened, we did not anticipate what could be the magnitude of migration problem, because these data are not talked of. These issues are not in public. We are not collecting the data. If we don't have data, then we may not have high visibility of the issues of the migrant population. So to prepare how population data can be used as a predictive force, then planning the resource, planning the response. What kind of resources will be required for health, for economic needs, for other services. Similarly, when we are in the recovery mode, what kind of population needs are there? What kind of population is vulnerable? How the different population groups have been impacted? The population data can be used to address those issues in the recovery or rehabilitation or mitigation stage also. Then in the end, what I would like to add, that it's not availability of data only which is important, but use of data also. And Mr. Venkatesh Srinivasan also pointed out that the NDME, National Disaster Management Authority, do they have the capacity to use the population data in their forecasting, in their response plans, as well as in their rehabilitation plan? Do we have enough population scientists who can be assigned to planning board in different states or the NDMA to work out on these. So use of data is also equally important, not only availability of data, as Dr. Urvashi was also saying, that understanding the data or making sense of the data is also very important, how we project the data. The number of cases high in one state that could easily skew the discourse in social media that cases are high there, but it could be because of the better testing. So how we use the data, how we project that data. Then projections estimation based on the population census. We need to have the denominator data so that we can plan accordingly for the needs of different population groups, whether it's the school-going children, whether it's the adolescent young people, or it's for the family planning, or for migrant, or for the elderly population. How we can have a disaggregated data for different population group to plan accordingly. Then, very important, it's also the visualization of data. Having the data, making projections, and then visualize the data so that it is available at the local level for people to see this. These are the different target population groups in these areas. When we start making an emergency plan or pandemic preparedness, we need to account for these different population groups. I think that is the takeaway from this session in a nutshell. Again, very informed discussion took place, and I'm really thankful to all the experts and panelists. We could have a good academician's perspective, practitioner perspective, as well as from the NITI Aayog, the government perspective also. And we hope to continue these discussions later on also, taking different themes. What we are thinking, Arjun and I are thinking that next we may have on demographic dividend, how decreasing fertility, it is going to affect the demographic dividend and different employment scenario or education scenario or skill building scenario, how that is kind of taking place, so that whether we are moving in the right direction. So next could be on demographic dividend in the context of decreasing fertility. And also we would like to have another session on health and budget, which is close to heart of Arjun. He has told me 2-3 times that we need to have something, how we are going to, especially in the context of what different communities and different population groups have faced, and the pandemic situation is still going on. So how health, how budget is going to be responsive to those needs. So we will be in touch with, and I'm really thankful because, and to all the panelists, this was the first session. So it is going to be a kind of a very close to our heart that we started with the 4 experts. Again, thank you very much. Hand over to Arjun.
Thank you so much, sir, and to all the panelists. To formally give a vote of thanks, now I invite Anshula.
Thank you, sir. And thank you everyone and all our panelists and our moderator for this very enriching and thought-provoking deliberation, which has been a wonderful way to kick off this series, Population and Development. So as we come to the end of this session, I, Anshula Mehta, Senior Assistant Director at IMPRI, would like to thank all of you on behalf of the IMPRI Center for Human Dignity and Development for joining us today for this web policy talk on population data and pandemic preparedness. We would like to thank Mr. Devender Singh for moderating and really steering today's discussion. Thank you, sir. We are grateful to all our panelists, Dr. Venkatesh Srinivasan, Professor Mala Ramanathan, Ms. Urvashi Prasad, and Dr. Kunal Kishri for taking out their time to join us today and for sharing their valuable insights and perspectives in this deliberation. Thank you. And of course, thank you to all our participants who joined us here on Zoom, as well as on Facebook Live, or would be watching us later on YouTube or listening to us on our podcast. We are grateful, and we hope that you continue to tune in to future episodes of Population and Development, as well as our other web policy talks. And with that, I wish you all a good night. Thank you.